All right, Anu, we are back. How's it going?
It's good. It's good. I'm super excited to see you at HFSA this weekend.
Oh my gosh, it's been so long. It was so sad to miss last year due to weather. It's going to be amazing to gather our community back together this year in Minneapolis.
Yeah, I feel like we've been doing so much in anticipation of this meeting that I'm going to be so excited to get on the plane and see you and see the rest of the team and so many other friends and connect at the meeting. I'm really looking forward to it.
Totally agree. What time do you get in?
I get in tomorrow night much later than I want to, but I want to try and catch the kids after school, and then I'll head straight to the airport. What about you?
Oh, Jinx. Yeah, I've got the same going on. My middle son, he's got a cross country meet tomorrow. So I'm on a late flight out after that. Glad to get to see him and looking forward to hitting the ground running once we get to Minneapolis.
I know. You better ping me when you get in.
Yeah, you bet. You bet. And then we'll have a busy day Friday and lots of fun JCF activities. And so it's just really going to be a great meeting.
Yeah, it's going to be packed. I'm excited.
All right, well, let's jump right in. Welcome back to JCF. I'm Dr. Robert Mentz.
And I'm Dr. Anu Lala, and we are your co-hosts and co-editors-in-chief of JCF. Today, we're going to be discussing two interesting topics and papers that are in the October issue. One on this HFSA education module and its impact on guideline-directed medical therapy implementation. And the other is where we stand currently with respect to defibrillators or ICDs with contemporary durable mechanical circulatory support from the HeartMate 3 study momentum. So, Rob, let's start with the first one. I think this is really interesting because what we know in heart failure is that it's not all about just innovation and finding new medications that work, but it's also about the implementation of these medications, right? And we have seen that there is a lag so many times due to fear of side effects, quote unquote inertia at times. And so this first paper looked at an educational tool developed by the HFSA called the Optimal Medical Therapy Certificate, which was this structured module to teach prescribers, physicians, nurse practitioners, pharmacists, other APPs, how to feel more confident and comfortable prescribing, dosing, and then monitoring guideline-directed medical therapy for patients living with heart failure. So over 400 clinicians participated, and the results were pretty striking. After the module, their comfort level with GDMT went up significantly. And I think this is the kicker for me, is the biggest improvements were really seen in the drugs like SGLT2 inhibitors, mineralocorticoid receptor antagonists, and ARNIs, the classes that are relatively newer or sometimes seen as more complex with side effects to start. What were your initial thoughts based on this paper?
Yeah, first, thanks so much for that nice summary. And I think this is a really important effort as we take a step back and see the role of HFSA as a society seeking to improve patient care. And what I loved about this was it was a rigorously developed module that had really represented the multidisciplinary excellence of HFSA. So it brought together nurse practitioners, physician assistants, pharmacists, MDs, developed this, focused on GDMT, as you noted, but then actually tested it. So they did pre-post surveys to get the experience of those individuals that performed the educational modules. And it was nice to see who was involved in the study, right? So it looked at community practices, academic centers. It was a wide array of different specialists too, some nurse practitioners, some MDs, pharmacists. So it really represents what HFSA is and what we'll gather together for the meeting this weekend. And then it was just as you described, testing the experience of those individuals. How was their comfort level after the module around starting medications, thinking about contraindications and monitoring that was needed? And it was just as you noted that it explored both the older therapies as well as some of the newer therapies. So it gives us the hard evidence to best understand the utility of offerings from the HFSA like this. And then it also sets us up for more work in this space. What really caught your eyes as you read through this one?
It's a reminder that education is low cost, it's scalable, and it can be used to help close this implementation gap. It's not a replacement, for our heart failure specialists, but it really does allow for broadening comfort amongst a wider workforce that's needed given the shortages in heart failure trained clinicians that we've heard so much about. And then lastly, I think that this really aligns with what we saw with the Strong HF trial and their protocol, but this is in a real world setting supporting aggressive guideline directed medical therapy titration. So I think, just as you stated so nicely, this work reminds us that even in 2025, one of the biggest barriers to heart failure care is not just access to therapies, but also clinician comfort in using them. And so I really like that this relatively low cost, easy to implement tool can democratize that knowledge around GDMT, empower APPs and primary care physicians, and ultimately, hopefully, improve patient outcomes.
Yeah, spot on. I think you said it nicely. We often see creative, potentially expensive strategies to try to enhance GDMT from different nudges in the EHR, and not to downplay the importance of those evaluations and efforts, but this idea of let's get back to the basics. Let's focus on education. And now we have nice data that show this improved comfort of different clinicians around prescribing and thinking about contraindications. And we've got a roadmap as we move forward. Let's see whether these efforts, as we now scale them up, can they lead to improved uptake of drugs and improved clinical outcomes. So this is a key step in the process, and excited to see where the investigators and our broader community goes from here.
Yeah, perfectly stated. So, shifting gears a little bit, let's talk about this second paper. This kind of takes us into the world of left ventricular assist devices, so LVADs and device therapies. For years, ICDs and CRT devices have been life saving in systolic heart failure. But once a patient has an LVAD, the role of these devices, I don't know about you, is less clear. Like, I'm always struggling. What do we do? Do we turn the ICD off? Do we turn the left lead off in pacing? So this analysis that comes from the Momentum 3 trial really asked this question. Does having an ICD or a CRTD improve outcomes in patients with a HeartMate 3 LVAD in a contemporary cohort? And for me at least, the answer surprised me. There was no survival benefit in patients with an ICD or CRT compared to those without a device. And I say this surprised me. I wouldn't say it surprised me because I kind of feel like I've seen that in clinical practice, and certainly in Sinai, we've adopted this practice. But it's so hard to let go of what we've known for so long, right? It's almost like we need to rewire our brains. Interestingly enough, those with devices actually had more ventricular arrhythmias, and there was no differences in hospitalizations, quality of life, or exercise capacity. And the last thing I'll say is that on top of that, device replacements and generator changes carried, as you would expect, notable infection risks. So, the takeaway from me, and then I really want to hear your thoughts, is that for patients living with LVAD support, the traditional survival benefits of ICD and CRT may not hold. In fact, I really don't think that they do. So tell me what your thoughts are.
Yeah, I think you summarized that beautifully. And it is, as you note, a question that comes up pretty often clinically. Maybe a patient has relatively new onset heart failure, but really advanced symptoms and gets an LVAD before they're even considered for an ICD. Or in this case, we have a patient population in a trial. So recognizing this is a unique patient population, but nicely they also included not just the randomized group, but also the continued access after the randomized trial, the formal study, and had a long-term follow-up, so 2-year follow-up in this group, and really nicely compared those patients with and without an ICD, with and without CRT, and began to take this deep dive looking at clinical outcomes, quality of life, and functional status. And I think you said it nicely that, well, in some cases, you say, goodness, what they've got this device in addition to their LVAD in place, we hope that they're getting some benefit from it. And actually, the authors demonstrated, no, there wasn't a clear benefit, and there's some risks that go along with that. And I think we have to take this with caution. It's not a randomized experiment around yes or not having the ICD at the time of LVAD or whatnot, but it gives us important observational data that there's not a clear benefit, and we might see more arrhythmias. And some of that has to do with they've got a device in place, so maybe we're more likely to see this clinical worsening leading to ventricular arrhythmias, hospitalizations. But from my editor hat, I'll say the things that I really liked about this is the investigators took an important data set where patients contributed to this trial and then said, what important question can we ask for the clinical community? And they performed an analysis that was really rigorous in the setting of the observational cohort. And I love to see that anytime when I'm reading a paper, they say, and I think, well, what about this? Did you adjust for this? And each sentence I'm reading further, you see, oh goodness, all right. So they did propensity analysis in addition to their multivariable adjustment, and it showed consistent findings. They did different sensitivity work to really demonstrate the robustness of this. So I think it really does weave together the story of an IC does not have a clear benefit in these patients, and there are risks. And some of the additional data, as you noted, around extractions needing to happen or infections and gen changes and things, that's often what we see in the clinical space, right? We don't necessarily see a clinical benefit with an ICD where the patient can be hemodynamically supported even through that with their LVAD, but they're coming in and getting a gen change, and since they're on anticoagulation, they get a pocket hematoma and risk of infections. So I really applaud the investigators for this important work. I think it builds upon some of the earlier studies and gives us this really contemporary cohort. So maybe Anu, as you're walking on rounds and teaching your trainees, what would you share with them, and how does this change your practice?
First of all, I love the way you go through these, and I'm not just saying that. I really do, because I think you hit the high note so consistently. I think your point about patients with devices being noted to have more ventricular arrhythmias is, one that we need to interpret with caution. The paper reports a hazard ratio of 2.4 versus those patients without a device. And you're right, because there is a device, we might be detecting more of those ventricular arrhythmias. But there are two things that really stood out for me, and I think you highlighted them both nicely, is that the traditional survival benefits of ICD and CRT, so this is both, I think, are likely muted, maybe because the LVAD itself is providing this quote unquote protection by virtue of hemodynamic support. So the two things that really stood out were, it really raises questions for me about whether we should be contemplating generator changes or de novo device implants in this population, because we're so used to kind of following traditional paradigms of practice. But this really raises questions about whether those procedures should be, approached the same way that we have been. I would exercise much more caution in thinking about that. That's certainly our practice at Sinai. I'm not sure about what you guys do at Duke. And then the second thing is that this really highlights the importance of personalized decision making, right? We have to balance the risk of arrhythmia in a given individual against the procedural risk and the patient's trajectory. So while we have these data, I always love taking it to the patient, taking it to the bedside, as I came off of rounds just last week, and saying, okay, how does this apply to each individual on a personal basis? So, this being one of the largest analyses to date, really summarizing or suggesting that defibrillators and biventricular pacing may not add or confer that additional survival or clinical benefit in patients on LVAD support is really helpful to me.
Yeah, well said. I was going to pull in the from paper to patient concept as well, so I love that. Well, unfortunately, that's all the time we've got. That's it for episode 3. If you haven't read the articles yet, please take a look at the October issue of JCF. We really think you're going to enjoy this one.
Don't forget to stay curious and connected with us at JCF.